Good morning, everyone, and thank you for inviting me to give this talk, a talk on the link between clinical microbiology and infection prevention and control. My name is Andreas Voss. I'm a clinical microbiologist from Nijmegen, the Netherlands, and to be honest, I'm mainly an infection control guy. And I'm apologize for not being there with you and not even being there live, but actually you don't want to see and hear me at 5 o'clock in the morning. So with regard to this talk, I believe that I have no potential conflicts and nothing to disclose, except that I do work with some of the companies and institutions that are visible on this slide. So with no further ado, let's start with my talk. And I wanted to start out with the fact that obviously multi-drug resistant organisms are permanently increasing. So looking at the global epidemiology, it's an easy trend. It's up, up, and up. And there are tons of publications written about it, and especially written about the need for global solutions. And I wanted to quickly go into this one because this one it's a very good one. It's in Lancet Infectious Diseases and by authors that are extremely well known. And it gave me a lot of hope when I saw this publication, which by now is a little bit older. What the authors state in the very beginning is that within just a few years, we might be faced with dire setbacks medically, socially, and economically unless real and unprecedented global coordination actions are immediately taken. And we a few years later, and they haven't been taken, and the last 2 years we obviously were busy with different things. Still, in that article, the author describes the global situation of antibiotic resistance, its major causes and consequences, and they identify key areas in which actions is urgently needed. And in this slide, you see the different actions that are needed. And it's from a nice general description by Ramanan and a few other colleagues. And into minimizing the time of effective treatment, rapid diagnostic, a topic I will go on to later on shortly, to One Health problems, to all kind of aspects that you could expect with regard to antibiotic resistance and the need for its solutions. I was mainly interested in part 8, beyond antibiotics, alternative strategies to prevention and treatment. And I thought, okay, this is where my field of interest comes. So when I went to that article, all I could read was about adjuvants, so compounds that potentiate the activity of antibiotics, antivirulent strategies, biological therapeutics, probiotics, and anything else except the only thing I was hoping to see, namely infection control. The authors actually forgot the basic infection control principles. And this, I believe, is an extreme pity, as we all know that infection control can be extremely helpful in two ways. Number one, in preventing healthcare-associated infections, and thereby the need for treatment, and consequently the need for resistant development, and it controls its transmission, and thereby the transmission of multi-drug resistant organisms. Both of these principles extremely important to prevent the occurrence and transmission of antimicrobial resistance. So having said that, I would like to come back to my link between clinical microbiology and infection control. And I want to do so by talking about defining the problem, making it visible, AMS support or antimicrobial stewardship support, and add-ons. And the add-ons actually is just typing out, so I could have mentioned that too. And I will do so by not drilling into details, but by trying to keep it into a helicopter view. So you won't see too much details or methods or anything else, but what you get is part of my personal opinion, how our system should be integrated together and how it should function and what we should be doing. And having said that, that's actually my first point I want to do. because in the link between clinical micro and infection control, I believe that we still have the idea that for the treatment of our patients, we have the diagnostic centers, clinical microbiology, the treatment group led by infectious diseases people, and the infection control group. And I believe that this is a very bad system. It's great to have all the specialties, but they shouldn't be separate. They should actually be integrated. We should have an integrated infection management. And then within that group that is working permanently together, obviously you have people who are more on the diagnostic side, more on the therapeutic side, or more on the prevention side, but together they should be one integrated group of infection management. And I think this is what we really do need. My second one was define the problem. And when I start to define the problem, obviously we have to define what are multi-drug resistant organisms. And this definition is needed not only for healthcare workers, but also for patients. And we tend to forget about patients, whereas this group of people is very confused when they change from a hospital to their GP or to a long-term care center, that suddenly the healthcare providers seem to use different definitions of what the multi-drug resistant organism is or how important it is. So we do need universal definitions. And those should be there, obviously, to be really universal within a country. They need to be national. There need to be the same definitions for all healthcare settings and the same definitions for all specialties within one care setting. And this is important to make it one clear, unmistakable definition of multi-drug resistant organisms. And for me, there are three key elements to an MDRO. Number one, it needs to be a true pathogen. It does not make any sense to use infection control measures with regard to contaminants. The resistant pattern should clearly limit the therapeutic choices one has. So, and the last and the third would be that the microorganism or the plasmid need actually to be transmissible. Otherwise, it doesn't make sense to try to stop transmission. And additional factors are that obviously the extent of the treatment limitations, it makes a difference if you're resistant to one or multiple antibiotic classes. It also the transmissibility and the chance to stop transmission should be done with proportional measures. In the order, the measures are more harmful to the patient than our infection control intent, then yes, obviously that is not what we want for our patients. And last but not least, I said care settings, nursing home versus hospital, and they all should use the same definitions, but doesn't mean that they have to use the same measures. Obviously, they can be different, but at least the definitions of a multi-drug resistant organism need to be the same in order for registration, surveillance, and other reasons. This is just a short example from a guideline that is under revision in the Netherlands at the present time. It shows you the microorganism and the resistance of it. And obviously there are certain resistant mechanisms that just have like a single enzyme or two in order to gain the resistance for the microorganisms. Examples of that would be the MAC-A or MAC-C for Staphylococcus aureus. And as you can see in this guideline, the authors are also considering Staphylococcus sargentis and Staphylococcus schweizeri to be included in this group. Another example of this would be Van A, Van B, and Enterococci, and then specifically in Enterococcus faecium. So you can see there's a single kind of enzyme or a single kind of mechanism, and then you have multi-drug resistant organisms. Or it could be, as in the example of Pseudomonas aeruginosa, that we actually talk about a combination of different resistance, in this case 3 or more, and then it could be to aminoglycosides, carbapenems, penicillins, ceftazidime, fluoroquinolones. So it's always a combination, and there are lots of many more of these combinations. These are just a few examples of how it's done. Most importantly, it needs to be done uniformly and preferably nationally. So having talked about the definition, the next part would be actually the detection. And the slide for that couldn't be better than this, I believe. You cannot control what you don't see. That is the basic principle of detection. So we have to make it visible. And the Netherlands developed the first national guidelines for detection of multi-drug resistant organisms in 2013. And the aim of this guideline was to make things standardized. So you have a standardized method to ensure that we all see the same multi-drug resistant organisms. But it does not only need to be standardized, it only needs to be optimized. So we ensure that we actually have the same chance to find those organisms. And this is a guideline that was from 2013, was supposed to be revised more slightly in 2017, and then again in 2020, which, two reasons you can imagine, wasn't done, but it will be there in 2022. Because this really are guidelines that need to frequently be changed and according to the new methods that are used in the field. I don't want to give you any real example from it. The main thing I want to say with this slide, and on the left you do see a flow chart for the detection of MRSA, and on the right you see the same thing, but within rapid laboratory methods. And what I want to say, you do not have to only do that for the standard microbiology method, but also for rapid detection, and that is extremely important. In talking about rapid testing or point of care, here's a picture of 4 systems, and there are multiple, and there are more in the market. I happen to use this picture as it has like 3 of the systems I'm using in my own lab. And I believe that by now we all have learned that making yourself dependent on a single system is a very tricky thing during a pandemic. So you better have different platforms to ensure that you can and have supply at any time you need it. But these rapid testing and point of care tests have 3 main reasons for why I believe that they are extremely important and that we need them in the interlink between clinical microbiology and infection control. Number 1, I believe that COVID-19 had made to us really clear that rapid testing is the basic for admission screening, cohorting, and efficient patient flow. My ER is fully dependent on me telling them quickly if a patient is supposed to be in a cohort for COVID-19 or a cohort for influenza, or can just be mixed with other patients. Another thing is that obviously infection control measures that should be taken outside acute care and outside healthcare settings with their own microbiology, rapid testing and point of care testing gives us a chance to actually apply the same measures also in these settings. And last but not least, an important client for this is occupational health. And not only to stop people from working, but more importantly, to get people back at work and thereby protecting the needed healthcare worker capacity. So certainly in the time right now, that's an extremely important function. So 3 good reasons why rapid testing and point of care tests are an important link between clinical microbiology and infection control. The next topic would be antimicrobial stewardship. And we all, we all know that that is usually done by the A-team. And the A-team is a huge mixed team from PharmDs to clinical micro-infectious disease, hospital administrators, infection prevention and control, and ICT. And it's not for no reason that I put the center of this all Hannibal for all those who knew A-team at clinical micro and infectious disease, because I really think this is the linking pin in it. And it should be linking really well with infection control. And Without going into too deep into the task of an A team, you probably all know them, but it's audit and feedback on antibiotic use, guideline development, projects to improve antimicrobial use, education, surveillance of antimicrobial resistance or possibly PPS on antibiotic use, development of ICT-based monitoring and support, and most importantly, and that's why I put it in here mainly, restricting choices. Restricting choices based on antibiotic guidelines, but then through adjusted clinical micro reports and to adjusted clinical pharmacy dispensing. And certainly the microbiology report is something I want to talk about. I call it old school clinical micro. Just think about an E. coli from urine from a patient from a GP, and you have the antibiotics as measured. So you can decide to either report it as measured and thereby allowing a physician to also use antibiotics that are only second or third line of treatment of urinary tract infections within the community setting, or you can report them by leaving out certain antibiotics. And that's what we call selective reporting. It's great to guide treatment, to protect restricted antibiotics, and obviously it can be done, it can only be done according to antibiotic guidelines that are existing. We shouldn't forget that it may have to be made specific per customer group, GPs, nursing homes, and others. And that is something actually most groups do forget about, that it should be accompanied by a 24/7 service, giving the physician the possibility to ask about alternative treatment that have been measured but not reported in case of allergies, in case of contraindications with regard to other medications given. So we do have to give them the possibility to actually ask for more 24/7. In addition to all that, we have to consider culture. And I like to use a traffic light, and I have to say that I stole it, I think 20 years ago from Barry Cookson, but by nowadays it's used by everyone. But I like the example of the traffic light and telling us about culture differences. And culture differences are kind of funny because the traffic light in England or in Germany, it's absolutely mandatory. In France, it's more a suggestion. And for Italy, it's more a Christmas decoration. So yes, restricting antibiotic reporting is a great way of influencing treatment choices and thereby possibly the occurring of multi-drug resistance. But you do have to keep your culture in mind. In my early years in Germany, I would have never been able to do it. New school microbiology is more about using technology and databases in order to give us good ideas about where we are with our resistance. So antimicrobial stewardship is accompanied by surveillance. And in the Netherlands, we use a system that all laboratories, or actually I should say 70 to 75%, dump their data overnight into a national system, and thereby have the possibility to create their personal reports or download standard reports with regard to resistance in any kind of setting they would like to look. It's also a click and system where you can do that. And these are examples for Escherichia coli, ESBL, aminoglycosid resistance, so the two in the middle, or the resistance against moxiclavulanic acid, the one on the right. And what you can always see that you can compare your own data in green to the average data of your nation, in that case, the Netherlands. For all those who don't have a national system like that, but you can go to the EARSnet, the European Antimicrobial Resistance Surveillance Network, to get comparable data. Again, you have the same thing here, a system that allows you to click away, click the antimicrobial resistance pattern you like to see, the microorganism you like to see, and the time area, and you can generate this great maps. That's why the reason it's also called Surveillance Atlas of Infectious Diseases. And please go ahead and have a good look into it, because I believe that data like this are extremely valuable to convince your clinical colleagues of what clinical micro and infection control has at one aim, namely to get good antimicrobial use and less multi-drug resistance. To control antimicrobial resistance in your hospital, more than just a good A team and these little tricks are needed, to be honest, I have to say. So you do need good treatment guidelines, and they should be national, like the SWAP for the Netherlands. You need national infection control guidelines, national resistance surveillance, national surveillance of healthcare-associated infections, and possibly also a national surveillance on antimicrobial use. So there is more and more surveillance and data you need to really guide your treatment and your infection control measures. In order to really get all these, you do need extremely active professional societies. And it does help if your country has an inspectorate that is actually looking into implementation of all that is needed, and we're using for their guidance the national standards and standards provided by the professionals. Last but not least, I believe that clinical micro, infection control, and ID should be in all major healthcare settings and the regionally cooperating. So that is what, in my opinion, is needed to achieve it. The last topic of my talk, I thought, was the add-ons, actually the typing. I don't want to go into it very much. I think that times changed a lot. Nowadays, real typing with regard to infection control is whole genome sequence based. There are great technical reports like these two from ECDC, but also from others. But what I really want to say, what is needed is for cluster analysis, epidemiology, or investigation of transmission surveillance, whether you do it locally, regional, nationally, or internationally. It can all be done with whole genome sequencing. And the nice thing, you don't even have to do like was in the old days with pulse-filled gel electrophoresis, where every time you wanted to compare strains, you needed to put the whole set in again. Nowadays, these data are stored in databases. You can compare them at any time. You can compare them over humans, over animals, over environmental isolates. So it's a great way for infection control, but also for epidemiology. An absolute need for a modern infection control group. Truly, my last slides is about something that is coming soon to your setting, or actually might already be there. It's about the future of clinical micro and infection control. And I should say future, but what I actually mean is, what I actually believe is that the future already began. Virtual healthcare will not be limited to how we contact our patients, but will change the patient mix and patient population in our hospitals, and will influence its architecture. So more bytes, less bricks, and thereby the place in which patients actually receive their care, its complications, and the need for support. Acute care will get far more complex, and thereby create a need for far more specialized hospitals. Long-term care will also get far more complex because they're getting a lot of the acute care patients, and therefore they need to have regional cooperation between the healthcare settings. On the other hand, long-term care will pass on some of their less complex patients into home care, and home care will need a lot of support. So as a consequence, we have to change and transform. We cannot continue in the same ways we are continuing for the last 100 years. Diagnostic really needs to get closer to the patient. It needs to get out of its present locations that are frequently stuck on to a healthcare setting. We need to move into new sites. We need to allow our customers far more freedom. Just think about self-testing in COVID. Self-testing was kind of poo-pooed on by clinical microbiology in my country in the pre-COVID area. Nowadays, 50% of the cases we detect are detected as confirmation of home self-tests from COVID patients. So it's something that really need to be transformed in our care for the future. And there are a lot of new business models. And there are completely other people doing diagnostics and also infection control. And talking about that and talking about business, this is a good example. The Walmart Health, primary care, counseling, hearing, dental, optometry, but labs and X-rays. And this is not a mock-up. This is truly existing. And they kind of think, and they probably are, closer, faster, cheaper, and have far better parking. But these people are following a business model. This is business. And I believe that healthcare, that we are going far further. We are interested in the patient and the best ways for the patient, but we have to make sure that we also change and deliver that in the right way. So I want to close with my last slide as the most important take-home message. And I believe it's a very easy one. You cannot control what you don't see. And thereby, I'm not only talking about the methods, how to detect multi-drug resistant organisms, but I would like to include the fact that you first need to standardize the definition of what is a multi-drug resistant organism. And the second part, and I thought went through all my talk, I'm a strong believer in integrated infection management, and we really should go for that. Thank you very much, and I'm wishing you all a good day in Singapore. Bye.